We are moving to the US. We are going to hear from Dr. Amy Chai, MD/MS. She is a board certified. Oh, sorry, my notes are messing with me. She is a board certified in both internal medicine and addiction medicine, and has worked for several years in the field of opiate addiction. Currently, she is working to prevent mental illness and addiction, addressing root causes through advocacy for public policy. And her talk has as a title, The Impact of Gender Identity Ideology on Women with Mental Health and Addiction Problems. So this is also very interesting to hear. Over to you. Thank you.
Thank you so much. Can you open my PowerPoint for me? Thank you so much. I'm going to be talking about gender ideology and the impact that it has on at-risk women who suffer from mental illness, addiction, sexually transmitted diseases, HIV, AIDS, and homelessness. These are the patients that I primarily work with. I am boarded in internal medicine, addiction medicine, and epidemiology. Next slide, please. What we have is something called the abuse to prison pipeline. And while these statistics that you see on your screen are sort of self-explanatory, I just wanted to quickly reveal a couple of personal stories of patients that I've had. When a new patient comes in with fentanyl addiction, they often have difficulty with follow-up, medically speaking. So I try very hard to make sure that their medical and mental health needs are taken as well care of as much as I can during that first visit. And there was a young woman who came in to see me with the fentanyl addiction, and I was examining her spine, and she was having a lot of tenderness along her spine, a lot of pain. And I was asking the usual questions. I said, did you pick up something? Did you have an injury? Were you hurt? And she kept denying everything. And then I said, well, can you think back? Is there something that you do repetitively that maybe impacts the health of your spine? And she said, well, I was chained to a bed for 2 years. It turns out that she had agreed to a date with a handsome young man who took her to visit some friends of his, and then they were traffickers, and they chained her up to a bed for 2 years, injecting her with fentanyl, and getting her addicted to the drug so that she would do, whatever she was demanded to do. That's the kind of trauma that people go through. Another example of trauma that I've seen, a young, quiet, frightened girl about this. She looked like, if you've ever seen a martini, she looked like a toothpick with an olive on it. She was pregnant, very pregnant, but she was just so skinny that all you could really see was her belly. She was very quiet, and I was trying to talk to her to calm her down, to make her feel comfortable, telling her that we would find, some place for her to stay and that everything was going to be okay. She could have her baby. I said, we're going to take really good care of you. We won't let anything bad happen to you because you're too important for that. And as soon as I said, you're too important for that, she physically flew back like I'd punched her in the face, because she couldn't hear that she was important. She couldn't hear that she was worth anything at all. That was an extreme reaction, but a lot of my patients have very low sense of value and worth. So what you see here is something we call the abuse to prison pipeline, where 70% of women prisoners have had forced sexual intercourse. which is basically what happens is women are abused and then they end up addicted and in prison. And in women who have opiate addiction and also they have delivered babies, there's a 100% rate of intimate partner violence. Next slide, please. Men and women are very different. There are very strong sexual differences between mental illness and addiction. We have something called dual diagnosis, which is where people have addiction and mental illness. There's a lot higher rates of mental illness in women versus men, as you can see from the slide. And primarily those are PTSD and mood disorders. The PTSD that women patient has is most strongly associated with their exposure to violence. And I have patients who don't want to see a male doctor. And I can totally understand they don't want the male hand, the male gaze, the male touch, and they want female counselors too. And that's what makes them feel safe and seen. So women with substance use disorders have a high prevalence of depression and anxiety compared to men. And usually the women start drug use because of these PTSD and mood disorders, whereas men develop the mood disorders after experimenting with drugs. Next slide, please. There's also a lot of sex differences in progression of addiction, and a lot of that is mediated by estradiol, which is the female hormone. There's a telescoping effect whereby women progress to substance use disorder much more rapidly than men. And they're much more likely to self-medicate for their PTSD, their anxiety, and their depression, which, as I mentioned, is almost exclusively due to trauma, and much of that trauma is sexual violence. And then, of course, the psychosocial factors that women face, lack of social support, and mental health symptoms make substance use disorders much worse for women. Next slide, please. So I went online to try to get a few data points for this talk. And on my way, I was looking at homeless shelters, HIV treatment, addiction treatment, trying to find out like cis women, trans women, reproductive issues. And along the way, I saw numerous red flags. And that's when this talk took a very dark turn. And now my talk isn't the same. Next slide, please. One of the first studies that I came across that I found to be problematic, I do have a master's degree in epidemiology, and I have done this type of ecological social study myself. So I know a problematic study when I see one. This study, if you would look, what do you notice about the power of the woman that is doing this research, which is Judith Auerbach. She's very well respected. She was director of Behavioral Social Sciences Program, HIV Prevention Science, and AIDS Research at the NIH, which is in the US, our national health system. And she was the Assistant Director for Social Behavioral Sciences at the White House, Institute of Medicine, and the National Academy of Science, which is our very, very top. This is very wonderful academic, powerful academic woman. So she has policy power. She has narrative power. She has political power. But what do you notice about the assumptions that are going on in this research? If you read the title says, "We are all women, barriers and facilitators to inclusion of transgender women in HIV treatment and support services designed for cisgender women." So if you notice in the title, what you're seeing is when you're doing an ecological study like this in social sciences type research, you're not really supposed to go in there with your own moral values or your own belief systems or your own ideas, or your own outcome in mind. You're supposed to be kind of neutral. And I feel as though, like, when you say we are all women as the first sentence in your research study, that's kind of imposing your value on your subjects that you're going to be testing. If I were going to do a study like Judith did here, I would have done a study entitled Beliefs and Experiences After Trans Inclusions in an HIV Clinic for At-Risk Women. Titles of research are supposed to be neutral, but this one wasn't. Next slide, please. The assumptions, when you look at the abstract, the very first sentence says, transgender women share more in common with cisgender women with respect to sociocultural context and factors influencing HIV risk, income, and outcomes than they do with men who have sex with men. So this was their very first basis for just saying that trans women are women. And what this study's basis came from was a prior study where they did genotypes of HIV for people who had sex with trans people who had HIV, okay, trans women, male to female trans women, who had sex with men and shared needles with men, and sexual contact tracing. So they got these HIV strands from the male to female transgender people with AIDS, and they traced back the source to their sexual contacts. And what they found was that a lot of the men they were having sex with identified as heterosexual. So they said because they were having sex with men who identify as heterosexual, they are actually women and they actually have the same risk factors as women. So instead of calling them MSM, which means men who have sex with men, they called them women. But interestingly, it didn't define gay men as straight for having sex with trans women. It only defined the people in relationship with other men. So this study was, I don't know, that was the study that they referenced in their reference list. So I'm like, okay, this is your first assumption, is that transgender women who have sex with men, which are men, isn't really men having sex with men. So anyway, I was confused, but let's move on here. Next slide. So the study results, they were saying that there was that most people were either willing to have an inclusive environment or eager to have an inclusive environment. And what that means is having male to female trans women in the same setting as women who had been victimized and were like living with HIV/AIDS. So it was they were trying to say, oh, are you willing to include the male to female in with the group of women? So there were 5 staff, and 3 of the staff were male, and 1 of them was male to female. There were 22 patients who were assigned female at birth, AKA women, and they were 16 assigned male at birth, AKA men, and then the 5 staff. So that was a total, the people that agreed to those, at least the 25 people who were either willing or eager, was 25. So there were 21 persons that were at least willing to have inclusion. So that means that 18 out of 22 women, assuming that all the men were willing to be included, 18 of 20 women were unwilling to have inclusion. So that was kind of the study results. And so the discussion of the results gives you a little more information about who was not actually on board with this inclusion. So go ahead and go to the next slide. So the discussion and conclusions were, I felt, quite hostile to women who felt uncomfortable with men in their spaces. I highlighted some problematic phrases that I found in their discussion and conclusions. Some may even feel emboldened by the women-only context, perhaps by a sense of privilege that comes with being a cis woman, to confront that person and demand their removal. So after seeing a large man in the bathroom, it was women's privilege that was hurting the man. And this was like a very negative thing. And then they said, at the same time, tensions do exist between idealized visions of such an environment and deep-seated sentiments and behaviors among some cis women towards trans women. And the goal of the study is to mitigate these gender-associated phobias. So everything about this study was how the cis women who didn't want men in their environment were bad and wrong and had like deep-seated behaviors that were not good. And if you read some of the data which they put in there, the questioners were like questioning the women in a way that they were trying to correct them, like, oh, you misgendered that person. And they're like, oh, I'm sorry, I didn't mean to misgender. So it was kind of, I felt like sort of a hostile questioning. Some of the material that I read, I didn't include any of the data. And then when they talked to the providers, what were the providers, that would be the doctors, what were the doctors concerned about? It says, providers were concerned that the fear of being traumatized in a medical environment lacking specialized trauma-informed competencies might lead to trans women to sit home and die. So what they were doing was they were kind of blaming women for trans men who might sit home and die because women didn't want them in their space. So what we see was the women are painted as the oppressors and the male to female are painted as the oppressed. And I get it. I want everyone to receive AIDS care. I care a lot. I have trans patients myself. But this kind of study portraying women's real emotions, real needs, real feelings, real concerns as problematic or bad or wrong is problematic in itself, in my opinion. Next slide, please. So I was trying to find then the effect on homeless shelters. A lot of my patients are homeless people with addictions. And I wanted to find out like what's the effect of inclusion or trans men and women's spaces in the homeless shelter. So I wrote some very specific questions to this AI tool that I have. And there's a thing called Open Evidence, which is available to physicians, and it has an AI tool to help us sift through piles and piles and piles of data and studies that we could never possibly read all through. There's just too many of them. So the AI tool helps us to kind of go through like what we are looking for. So the first question I said is, how many studies of homeless shelter outcomes specifically focus on gender diverse and LGBTQ patients? And how many studies of homeless shelter outcomes specifically focus on cisgender women? So this is what the AI, the bolded at the bottom is what the AI gave me back. It says at least 16 studies specifically focus on gender diverse patients, and at least 39 studies specifically focus on cisgender women in the context of homelessness. And so that was the first iteration of my question. So I started looking through the papers. Next slide, please. The second iteration, I would like to compare direct numbers of studies of homeless shelter outcomes for gender minorities and studies of homeless shelter outcomes for cis women. I mean, I was trying to get it even more and more like clear to the AI what exactly I was looking for. And it gave me the same answer. Cisgender women, 39 studies, gender minorities, 12 to 16 studies. And then it said the direct comparison shows cisgender women are the subject of more shelter outcome studies than gender minorities, although the gap is narrowing. Next slide, please. Third iteration, I asked the same question in a little different way. Were the studies on cisgender women specific to cisgender women only, or did it also include trans women, inclusive in the studies of outcomes for homeless women? And the answer it gave me was most studies of outcomes for homeless women focus specifically on cisgender women, but some recent research and systematic reviews are inclusive of both cisgender and transgender women, or explicitly distinguish between these groups. Next slide. Fourth iteration, still no answer. What percent of these studies were explicitly designed for cis women only? The majority of studies on homeless shelter outcomes for women are explicitly, read this one, the majority of studies on homeless shelter outcomes for women are explicitly designed to include only cisgender women rather than being inclusive of both cisgender and transgender women. Next slide. Fifth iteration, I call out the AI's BS. How can you say that the 39 studies on interventions to improve mental health in homeless shelters were explicitly designed to include only cisgender women when inclusion criteria stated people who identify as women or girls? Okay, so it answered me this way. In summary, unless the systematic review or its included studies specifically report on the inclusion or exclusion of transgender women, it can't be assumed that all 39 studies were designed for cisgender women only. We see a little bit. Some may have been inclusive, but the majority likely focused on cisgender women. Next slide. Sixth iteration. We're getting there. Thank you for being honest. Can you find any study that explicitly includes only cisgender women and excludes transgender women? Based on the available literature, there are very few, if any, studies of homeless shelter outcomes or interventions that explicitly include only cisgender women and specifically exclude transgender women from their participant criteria. It took me 6 iterations to get the truth out of AI. In fact, none of the studies focused exclusively on cis women. All of them were inclusive of anyone who identified as women or girls. No studies have been done at all on cis women only. They were only inclusive studies and male to female studies. I did 6 extremely specific queries into this database, and I never got the true answer. I never got it. Okay, next slide, please.
May I say something at this point, Amy, because I think it's going to be interesting. I know that you're a signatory of the declaration, so you're on board with us, and this is very interesting because it's very specific on the health field.
Yeah.
And all of us who are not involved professionally in this kind of academic or medical field, maybe we are completely out of this context. But here, just in case, because later when you finish, you're going to read the comments and all that, we are very specific on our language. And because the declaration is called Declaration on Sex-Based Rights, we only use sex-based language. So we don't use cis, we don't use trans. And
Yes.
we understand that you were quoting the titles and the conclusions of the topics and all that. So, but this is some just so you know that our position, as I said, is sex-based. So we understand exactly what is going on, and the AI sometimes is very biased. Depending on if you ask Google, you're never going to have a straight answer. I think Copilot is a little more neutral, Grok, because it's developed by Elon Musk, who has interest in this area because his own son was caught into this mess, and now his son identifies as a girl. So it's personal for Elon Musk. So Grok is more on the sex-based language as well. So even intelligent AI, artificial intelligence, also has the bias of the programmers. So
Mhm.
if you have any question to Gemini, to Google, they are going to feed you a lot of, excuse my language, bullshit about identities, and they're going to talk about how victims, how victimized they are, how vulnerable they are. So even different AIs are going to show you the bias of the people that were programming them. As that is for the AI part of the comments, and for ourselves, feel free to refer to men as men and women as women, because we
Okay.
are not offended. I understand at the beginning it's quite, people, women or people in general feel they have to be cautious because there's so much sensitivity over there, and some people react very violently if you misgender someone. That we understand that many people, are very cautious and have to, I don't know, I feel they have to not apologize but explain that I'm not a bigot. I don't
Yeah, I
I
know.
I don't want to cause any
Yeah.
harm, but this is what I think. So we are fine with sex-based language. You don't have to apologize for anything. Feel free to refer to people depending on their sex. You're a medical doctor. You know exactly better than I do that physiologically, anatomically, there are two different systems. The endocrine system, the reproductive system is completely different. So sex
Right.
is, as you started your talk saying, the behaviors are different. The context, the past experiences are very different. So feel
Mhm.
free to refer to men as men and women as women, and I am you will feel some relief when you
Yes.
when you allow yourself to do that. You will feel lighter. And sorry to say that, because there were comments on the chat, and later on, if you read that, I wanted also you to understand the context of our comments. We've been doing these
Right.
webinars for over 5
Right.
years, so we discuss this gender madness issue every week. So feel
Yes.
free, and
Okay.
okay, please
Yeah.
go on.
So,
Thank you.
okay. So I do also want to mention that in the context of, oh, my background screen today. I wanted to just say, like, in the context of when you're doing scientific research, you do kind of have to use the terms that they're using, unfortunately. But you're right. Women are women, men are men, and men are now women. I totally agree with that. And in the context of, like, what I wanted to say with this talk is that the most vulnerable, the most abused, the most traumatized, the most victimized women that we have in our country are being completely silenced, and completely unheard. And we cannot know the truth if the tools of knowledge, which is our research and our academic spaces and our biased AI, is excluding women. It's excluding women, or it's mixing women in with men. So what we see is that we are rapidly losing power in the narrative of who we are. And as we lose the narrative in medical science, we are called science deniers, or worse, we can be fired. And this is Lysenkoism. It's weaponized science against women That's my personal opinion. And it's also my husband's opinion. He is a pelvic surgeon and does a lot of bladder research and is being forced to include men in his study of women's bladder health and pelvic floor issues. Um, so the science is being tainted by ideology. Science is not ideology. Science is looking for truth. And the truth is that men aren't women. And we need to fight for science, and we need to fight against biased AI, and we need to call out the research that is silencing women. And that's my talk. So thank you for listening.
Oh, thank you very much. I didn't know you were on your last slide. Otherwise, I would have waited. I thought you were in the middle because you could have gone forever. I mean, it was very interesting, and it was very telling that the research being done on homeless shelter, which is a huge problem. One of the main faces, or one of the, how to say, women that are homeless are so vulnerable. Women in prisons are as well. So we find that it's a special kind of cruelty to have those women that have been, as you said, victims of sexual violence and violence in general, and they have a lot of mental health issues, but they have to share their spaces with men that are violent many times. And also they have to lie. They have to not believe their eyes, their feelings, their safety feelings that, or the unsafety feelings that they have, in that they have to deny all that, which I guess is going to make their mental health worse. So it's a complete nightmare in that sense. So thank you very much for bringing some light to this very, very delicate topic.